So this we are continuing the pre and post operative. This we have seen about this diabetes mellitus, steroid therapy, regarding hydrocortisone, thromboprophylaxis for children doesn't need, for higher risk patients which are above 60 years and all that, hypothermia. What about how to control hypothermia? What are the ways? This is J wave seen in hypothermia. So now we are going to see for the following increase in hypothermia. So ASA grade, temperature less than 36, regional anesthesia, combined general and regional, this can increase major or immediate surgery, emergency surgery, pre-operative phase 1. Temperature less than 36, surgery elective, do not operate, postpone it. So this is about temperature. Now ASA grading, no systemic disease, localize. Mild systemic disease without limitation, active smoker or alcohol consumption, pregnancy, obesity, all these come under grade 2. So smoker, alcohol, hernia surgery, patient is pregnant, obesity, control diabetes and hypertension. Just we have to remember these points to label it as grade 2. Grade 3 is again alcohol abuse, morbid obesity, poorly controlled diabetes mellitus, BMI is more than 40. Patient is having COPD, and this is ejection fraction 40 to 30. So ejection fraction is important. This comes under 3. Significant limitation. More than 3 months history of coronary artery disease and stenting, myocardial infarctions, these are also coming under less than 3 months. 3 months back they have undergone this. Pacemaker, patient is having pacemaker, end stage renal disease, active hepatitis, all these come under ASA grade 3. These are 3 grade. Now grade 4, what are grade 4? Grade 4, these are supposed to be a patient with severe systemic disease and threat to the life. Ejection fraction less than 30. This is the question. Less than 3 months. Okay, this is more than 3 months. If it is more than 3 months, it is 3. Less than 3 months, it is grade 4. Renal disease, sepsis, DIC, perforation peritonitis, grade 4. Grade 5 are very moribund patient, means with or without surgery patient cannot survive. That's why this is the table death consent. Impending rupture, aneurysm, aortic, massive trauma, intracranial bleed, mass effect, bowel ischemia. These are grade 5. Other scoring systems, Apache scoring, physiological, chronic health, critical care, it is for ICU, physiological chronic health. POSM, PO is for operative, morbidity and mortality, age, signs, symptoms, all these are taken. Operative severity scoring. NELA, National Emergency Laparotomy Audit, this is an audit. Charleston predict 10-year mortality for patient with comorbidity, not used in perioperative. This is not perioperative, it is 10-year mortality. News score, this is important, urgency responding triage, news for triage. So Charleston, NELA, POSM, Apache, ASA, these are for perioperative mortality. So this is about rapid enhanced recovery system, pre-operative counseling, intraoperative, post-operative. Important is prophylactic antibiotic. Questions are coming on this: carbohydrate loading, prophylaxis with the DVT, correction of anemia, and smoking. Multimodal analgesia is useful. Regional is better. Minimal invasive surgery, laparoscopy is good. Antiemetic is also one of the part. Use of nasogastric tubes has to be limited. Hypothermia should be prevented. Goal directed fluid therapy is important. Early ambulation, nutrition good. removal of early. Locally ZX procedure, you are giving short duration, mechanism of block sodium channels, intralipid is antidote 3 milligram, 7 milligram with adrenaline, without adrenaline. Bupivacaine is long acting, epidural analgesia, long duration, 2 methylene blue. For this is methylene blue. Prilocaine is methylene blue, and intralipid is for. So if any complication is there with prilocaine, you have to give methylene blue. So calculation is whatever is 1% divided by 10 weight into, it is 2% divided by 20, 0.5% divided by 5. Spinal anesthesia L45 iliac rest is given, sensory motor, epidural anesthesia, cognitive. Caudal is used in inguinal hernia, circumcision, piles, and adults. Patient control anesthesia. This is basically for post-operative appendicectomy pain and all that. Tab block in laparoscopy and all, transverse abdominis block. General anesthetic agents. Induction, propofol, antiemetic, good antiemetic, analgesic is also there. Ketamine, shock, traumatize. Succinylcholine is depolarizing. Atacronam non-depolarizing. Side effect is release of histamine is there. This is malignant hyperkalemia, malignant hyperthermia, delayed recovery. Dantrolene is used for this reversal, neostigmine for this reversal. Halothane causes hepatotoxicity, malignant hyperthermia. Isoflurane, most airway irritant. Sevoflurane for the pediatric use, nitric oxide adjuvant. If there is intraoperative bradycardia, use atropine. Use isoprenaline for bradycardia with history of heart transplant. Urgent pacing for heart block, bradycardia, isoprenaline. For urgent pacing is if there is bradycardia due to heart block. So now intravenous access, different types. This is peripheral vascular, for unsuitable for potassium supplementation. Disadvantages: air embolism, easy to insert. Peripheral is an air embolism. Peripherally inserted central. These are peripherally inserted and it is passing up to the central. They are less prone to the complication. TP and home can be given. Now these are centrally tunneled. There is a tunnel in the skin. You can see there is tunnel. This is the tunneling. This is the internal jugular vein. So these are Groshong, Hickman for long therapy of chemotherapy. If not available, pediatric Portacath. This is central. In an emergency, if you are not getting in line, put intraosseous line. Now this is important. IV fluids. The most important is Hartmann for resuscitation. Saline contains sodium and chloride. Hartmann contains sodium, chloride, potassium bicarbonate. All 4 ions. These are anions and cations. Cations and anions both are there. Sodium 131, chloride 111, potassium 5. This is 29. Requirement is around 50 sodium for one person. So half saline is enough. 70 to 50. Bicarbonate contains maximum. Fluid rich in sodium or bicarbonate more than saline. Dextrosaline contains only 30 sodium chloride. So feature commonly used in IV fluids are, this is the question most of the time asked, sodium chloride is hyper 0.9 with glucose. Osmolarity is increased, hyperosmolar when glucose. Plain 0.9 sodium chloride, if it is there, it is isomolar, isotonic. 0.9 is isotonic but hyperosmolar. Osmolarity is more because adding glucose increases osmolarity, but tonicity is isotonic. Hypertonic, when you increase salt, it increases tonicity. When you increase sugar, it increases molarity. Sugar molar. tone salt. So when there is 0.9 is isoosmolar isotonic. Sodium chloride 0.4% with glucose is hypotonic hyperosmolar. Only glucose 5% is isomolar, 5% hypotonic. Tonicity is less. %10 is hyperosmolar. 10%. Hartmann is isomolar isotonic. Hartmann and normal saline are same. This is isomolar isotonic, isomolar isotonic. Hartmann normal saline. Albumin is isomolar isotonic. Fluids in different ages. In neonates, what you give in neonates? Dextrose, sugar, 10%, 10% dextrose. 1 day, 2 day, 3 day, 4 day, 5 day. 1 day baby 60, 2 day 80, 3 day 100, 4 day 120. 5 day 120 to 150. 60, start from 60, increase 20 every. Pediatrics, you give normal saline. Maintenance is NS. This is 20 ml per kg. Resuscitation maintenance is 100 first 10. So up to 3 days baby can be of 10 kg. So 100 first 10. This is about 10 kg. Just remember. Per kg. Per kg. This is 3 days, no? This is 0.9 saline, 100 ml first 10 kg. Then 50 ml second 10 kg. Then 20 ml next about 20 kg. Or you can call it as 4 to 1 formula. For adults it is normal saline or Hartmann 500 ml. Reassess the solution. Hartmann solution, then as reassess and may repeat 500 ml saline or Hartmann. Resuscitation after trauma. Oliguria post-operative or fluid challenge. Whenever you are giving fluid challenge, give Hartmann 500 ml, then reassess the situation and may repeat giving 250 to 500 ml. Maintenance is daily requirement post-operative is 20 daily requirement post-operative in 24 hours. 1 liter normal saline, 2 liters of glucose or 1.5 liter glucose. So the colloids are not free filtered across semi-permeable membrane, so preferred than crystalloids. Used in hypoalbuminemia, hepatic patient. Dextran is used in DVT. Solve these problems but still have small size. Hita starch large size. Blood transfusion. When blood transfusion in chronic anemia, HB reaches 7, it's okay. When HB reaches 7, give oral. Below 7, you can give transfusion. Oral can be given above 9. Oral iron anemia at least 4 weeks. IV iron required if patient is gastric bypass. Usually used in correcting clotting deficiencies. Plasma. Fresh was down 24 hours. Platelet concentrates in thrombocytopenia. Cryoprecipitate factor 8 and 13. Wall blueprint. If someone has blood transfusion, he will not be able to donate blood forever. Transfusion FFP11. Massive transfusion protocol is loss in 24 hours. Half of its blood volume in 3 hours. 150 ml in 1 minute. So 24 hours 3 hours, half of blood volume, half all blood volume in 24 hours. It's 5 liters if someone is losing in 24 hours, or 3 hours in half, or 150 ml in 1 minute. Complications are hypothermia, hypocalcemia because of chelating, hyperkalemia, increased potassium, coagulopathy, overload, congestive ARDS. Causes of coagulopathy: massive blood transfusion, hypothermia, impaired platelet clotting factors, acidosis, inhibiting clotting factors, citrate toxicity, and decreased calcium impaired hyperfibrinogenemia. Cell saver devices, these collect the patient's own blood supply, and infection and malignancy are the contraindications. Complications of blood transfusion: acute hemolytic reaction, host antibody destroying RBCs. Host antibody destroying donor RBC. So occur 24 hours hypotension, tachypnea, dark urine, life-threatening reaction can triggered by few ml of blood hour. So EBA incompatibility, acute hemolytic, delayed hemolytic, host antibody destroying donor RBC, ABO, host antibody destroying donor RBC. Febrile reaction, host antibody against WBC. Against WBC. Fever mild, mainly in multi-transfused patient and thalassemia patient, and may abdominal pain but stable duration 1 to 6 hours. Post-transfusion purpura, transfusion-related lung injury. Donor plasma has antibody against HLA, non-cardiogenic pulmonary edema within 6 hours. Graft versus host, T lymphocyte attacks immunocompromised, pancytopenia, delayed hemolysis, RBC hemolysis, jaundice, stored blood changes, pH decreases, causes acidosis, ATP decreases, 2-DGP decreases, potassium increases, clotting factor decreases. During hemolysis, haptoglobulin decrease and it binds to hemoglobin, HB. Unconjugated bilirubin increases, reticulocyte. Post-operative complication: atelectasis 1 day, UTI 3rd day, wound infection 5th day, DVT pulmonary DVC and pulmonary embolism. Fever with local symptom day 5. Bulbar palsy, swallowing modification, upright position, upright, small pits, food modification, nasogastric pig, swallowing, decreases, reduces work of breathing, may useful weaning ventilator. Pneumonia, post-operative high fever, productive cough, dyspnea, chest pain, pleurisy, dyspnea, productive cough. Aspiration pneumonia, aspiration mainly contains symptoms may appear within hours according to severity, mainly on the right side, erect posture, supine, streptococcal pneumonia, mainly community acquired dullness and hospital acquired bronchopneumonia, lobar and broncho. Multiple bilateral consolidations, dullness over one lobe. Pulmonary thromboembolism, DVT thrombus 5 to 7th day, pathology thrombosis, pulmonary embolism, lung perfusion, ventilation mismatch increases, non-stable. Clinical picture is non-massive stable. Pleurisy, chest pain, hemoptysis. Massive stable, tightness. Massive unstable, tightness chest, cyanosis, congested neck veins. EC changes, V1 to V3 T changes, tachycardia, depressed S, Q wave, right heart pattern. This is embolism from the right side, it's going from the right atrium, right ventricle, causing right pulmonary embolism. So this causes dilatation of the right ventricular stream pattern, right axis deviation, right frontal branch block, and depression S, depressed S in lead 1 and Q inverted T in lead 3. Echo changes in massive pulmonism. Right heart changes. Right ventricular dilatation. Right ventricular diameter is more than left ventricle. Hypogynesia. Right ventricular global regional. Often sparing right ventricular apex McCollin sign. Intraventricular septal bowing. Septal bowing towards left ventricle. Left heart changes. Small left ventricle. Decreased left ventricular volume output causes impaired left ventricle filling and reduced systemic perfusion. CT pulmonary is the best investigation of choice. Treatment is non-massive stable, IV anticoagulants, low molecular weight heparin. Massive unstable thromboembolism, vena cava filter. Fat embolism, fractures, long bones, ECG changes, pulmonary embolism, thromboembolism, fat embolism, day 1, 5, 2. This is first day, this is 5 to 7 days, neurological symptom, rash, petechiae, and adequate oxygen and ventilation, base support, prophylaxis, and nutrition. What is ARDS? Non-cardiac pulmonary edema. This is non-cardiac. Capillary wedge pressure is less than 18. Major plus Swan-Ganz catheter. Main trauma, sepsis, pulmonary edema leads to diffusion. Reduced diffusion. This is the question. Because of reduced diffusion, which is the main reason of hypoxemia, considered as type 1 respiratory failure. Bilateral pulmonary infiltrates, cardiogenic pulmonary edema, pulmonary edema due to heart failure, same symptom and X-ray, but differentiated by history and pulmonary wedge pressure is more than 18. Treatment of the cause: low dose steroids to prevent infection, negative balance, low CVP, diuretics, ventricular pulmonary vessel decrease, respiratory support, PEEP positive, PEEP is given, inverse ratio. More than 70 post-operative pain, local anesthesia, sodium channel to decrease depolarization, TENS which activates sensory fibers, lateral inhibition of C fibers of pain at dorsal horn of the spinal cord, so-called spinal gate theory. Management of pain strategy: WHO ladder, paracetamol and steroids, then codeine, then morphine. Specific constitution: chronic pain, localized bone meds, radiotherapy, persistent pancreatic neck pain, nerve block, non-opiates, low dose inhibit COX-1 inhibitor, acts anti-inflammatory and cause peptic ulcer. Also high dose anti-inflammatory analgesic. Inhibit COX, so inhibit prostaglandin. Pediatric dose 10 to 15 mg per kg dose, maximum 60 to 80 mg. Paracetamol dose is 10 to 15 mg per kg dose and maximum is 60 mg per kg. This is 10 to 15 mg per kg. 10 kg is 16 mg. Side effects of morphine: toxicity, respiratory center depression, biliary spasm, constipation, itching, pruritus, bronchial asthma. If needed, saturation goes loss. Oxygenation through the bag and valve. Naloxone is an antidote. If there is morphine, reverse it by naloxone 0.4 to 2 mg. Chart review: analgesia. Patient is prescribed analgesia is given. Analgesia is appropriate for patient not symptoms: sweating, hypotension. Rib fracture analgesia: single rib fracture, oral discharge, single rib fracture, old admission analgesia, flail chest, severe hypoxemia, intubation, pneumothorax, chest tube insertion, flail chest, neuropathic pain, prolapse disc, host herpetic, traumagen. First line is amytryptyline, cause of hypotension, pregabalin. If it is orthostatic hypotension, give pregabalin. Second line treatment: combination of both. Specific: pregabalin for breast cancer, carbamazepine for trigeminal neuralgia, and duloxetine for diabetes. Diabetes, duloxetine. Pregabalin, breast PB, breast cancer. Carbamazepine for trigeminal neuralgia. Post-operative nutrition: esophageal jejunostomy, esophageal rupture, nil by mouth, rapid recovery, nasogastric tube, slow recovery, percutaneous and PEG, pancreatitis, nasojejunostomy, necrotizing pancreatitis, large dose, TPN is indicated. Ischemic bowel disease, high output fistula, TPN at hospital, short bowel syndrome, TPN at home, Eating at home, weight loss, elementary diet, removal of the ileum, only oral feeding. Refeeding syndrome, 5 days of starvation, then feeding causes metabolic changes, decrease fluid, decrease potassium, magnesium, calcium. Go to avoid refeeding syndrome, start with low calorie diet. 10. Then increase gradually 4 to 7 days. You have to give thiamine, you have to give potassium, magnesium, phosphorus. So BMI less than 16, high risk if one of the following: BMI less than 16, weight loss 15, little intake less than 10, potassium level, or two of the following: BMI 18 and above, 10 weight loss 10%, here is 15% 3 to 6 months, 10%, little intake 5 days, history of alcohol. Severe malnutrition characterized by protein, energy, and carbohydrate, muscle wasting, growth retardation, skin changes, fatty liver. Decrease risk of post-operative infection. Do not use clippers. Do not use clean wound without prosthetic implant. Clean wound use in clean with prosthesis contaminated. Hand wash, antiseptic solution. First time alcohol, then antiseptic skin preparation, alcohol-based chlorhexidine, povidone iodine. Do not use surgical incision. Wait for evaporation. Criteria for dilated fixed pupil, no cornea, cuff, vestibulocochlear reflex, no response to supraorbital pressure, no respiratory effort. Ventricular for 1 minute. Test should be taken by experienced doctor, at least 5 postgraduate.